know all the intricacies of, but I think it's a really interesting area. And the important message for your patients is that they can live well with heart failure, as paradoxical as that sounds, because there's an awful lot of it in the community, and there may be people in your family who either have or had heart failure. We're going to talk about the differences between systolic and diastolic heart failure. And we'll talk about not only the medications that are used to treat, but some non-medically based therapies, non-drug therapies for managing, and what are the guidelines for practice. So like I say, I don't care where you work, even if you don't work in a hospital, you will treat and come in contact with patients with heart failure. And why is that? Because there's so much of it. It's the one cardiovascular diagnosis that's increasing in prevalence in the United States and in fact worldwide. I get the privilege of actually presenting in Europe this year at the second heart failure conference, which is going to be in Sevilla, Spain. I'll share some of the work that we did at Stanford. I'm very excited. But everybody's struggling with it. Everybody's struggling with it. And why? Well, we're living longer, so there's also more and more heart failure. Heart failure, very simply put, is just the inability of the heart to keep up with the demands of the tissues and organs of the body. That's a super simple definition, but it's really all you need. That says it very succinctly. And the thing about heart failure, it's a clinical syndrome. I like that word, syndrome. Syndrome implies that it involves many more organ systems, and indeed heart failure does. It's also a circulatory or hemodynamic disorder. That seems like a given. Okay, my heart's not working well, probably have a crappy blood pressure. Yeah, that's true, if you're decompensating. And I may not be perfusing my distal organs, so I'm going to be cold and clammy and feel like hell, and I'm not making urine. Yeah, heart failure, especially acute decompensated heart failure, will result in all of that. So it's definitely a circulatory disorder. But I want to impress upon you it's so much more than that. Heart failure, the heart not working well, affects the kidneys, it affects muscle function, it affects the digestive system, it affects the liver function. The liver can actually become congested. It is in effect a neuroendocrine disorder for the very things I told you about. If your body's being insulted, it goes into fight or flight mode. It's just biology. And when it does, you get inflammation and the body attempts to compensate for this lower than normal cardiac output. It's not seeing. Remember, we've got baroreceptors in our bodies, right? Aortic arch, various parts of our bodies are carotids. If our body feels like, whoops, there's not enough blood coming out of here, it's going to do some compensatory things. What's the first thing it does? The very first thing it does, you have this neuroendocrine flood, and you have tachycardia. Remember, tachycardia is a double-edged sword, because heart rate times stroke volume is your cardiac output per minute, expressed in liters per minute. But if your heart is going so fast, there's no time for filling, your stroke volume has gone down, and your heart's being flogged. So that's a very bad thing in the end. That's why we give those medicines like beta blockers, like ACE inhibitors, to interrupt this normally compensatory cascade that ends up being very deleterious and altering the structure of the heart, and you've got a person who's effectively a cardiac cripple. So we want to interrupt that, we want to support the heart function, and of course it's a fluid balance disorder. Why? Very simply put, our hearts are pumps, right? You can be really unromantic and say it's no more than a very specialized muscle that its job is to pump fluid in our bodies all our days. That's it. And so if it's not doing a good job, the fluid backs up in the plumbing, and I explain that to patients about why they have incessant coughing at night, why they may wake up, bolt upright in bed, gasping for breath, which is called paroxysmal nocturnal dyspnea. These are very distressing symptoms because the heart is so intimately connected with the lungs on either side of the chest. And show them pictures. I have an iPad with drawings that they can see 3D imaging and different views, and they get it. They understand now, and they're starting to correlate symptoms with what's going on in their heart and their heart health. So there's two flavors. I'm really simplifying this, but there's basically two flavors of heart failure, and patients can have both at the same time. And so I explain it to patients using really simple, non-clinical jargon. We tend to talk in jargon because that's how we work as clinicians, but we have to think about not doing that with patients. So I tell them that if they have what we used to call systolic, or can still say, systolic heart failure, which is basically loss of contractility. Now have maybe this very stretched out, boggy heart that doesn't contract well. they have a squeeze problem, and patients understand that. And if, like a lot of elderly women who actually have normal contractility, normal ejection fraction, which is a commonly alluded to marker of heart function that you will hear and see documented in the chart, if they're normal there, but they have very stiff, non-compliant ventricles that resist filling during diastole, they have a filling problem. That's called either diastolic heart failure. The new nomenclature is heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, HFrEF and HFpEF. I don't use those terms with patients. They wouldn't get that. They get the squeeze problem or the filling problem, stiff ventricles. They can understand that. And again, many patients have both. So it's a huge problem. It sounds like hyperbole, but it is a public health crisis. Why? We have a finite number of healthcare dollars in our country, and I could go on and on about how our healthcare system is not very well designed at all. It's very frustrating when you see patients needing drugs and they can't afford them, and all these issues that they have to deal with on the outpatient basis. We have probably 6 million patients, and if you read the literature, like Paul Heidenreich, who's at the VA, his papers, and he's with the American Heart Association, we have this looming population bomb of a lot of patients with heart failure, probably my generation. When we get older and become seniors, there's going to be a hell of a lot more of us, and it's a burden. It's a burden on public health and our collective resources. So what CMS, and I don't know if you know what Centers for Medicaid, Medicare, and Medicaid are, they're the financial arm of Medicare, CMS, and they have started imposing penalties on hospitals, acute care hospitals, for more than a certain number of acute patients. Let me make this real simple. If you have a patient come into the hospital with heart failure, and actually if you have them come in with pneumonia, acute MI, hip surgery, a number of diagnoses, if they come back within 30 days for any reason, and frankly, even if they slipped on a banana pill, we're now a trauma patient, the hospital gets penalized. And how they get penalized is pretty severe. What they look at is a number, they do some risk adjustment for your population you serve, and if a certain number higher than a threshold come back to your hospital, and they put it in the newspapers, and they put it online so everybody can see, you get penalized all charges, a certain percent of all charges. Let's say 1% of all Medicare charges for the year, and for a hospital like Stanford, that would literally be millions of dollars. So it's going to hurt a lot of hospitals and a lot of centers. Is it a good metric for quality care? I'm not sure, because let's face it, our patients with MI and heart failure usually have many other medical diagnoses, chronic diagnoses, like diabetes and COPD, for instance, and arrhythmias, chronic AFib. There's lots of reasons why they could be coming back to hospital. But it's now in place, and a lot of hospitals are very worried. But I do agree with the philosophy that we've not paid attention to transitions of care. Patients come into hospital, we treat them, we send their insurance a bill, and when they leave our doors, bye, good luck to you kind of thing. And we don't, unless we're Kaiser or the VA, we don't see them again. And if they come back, so what? We just send another bill, right? That sounds like a good economic plan. Well, no, that's really wrong. It does patients a disservice. We've never paid attention to handing over in transitions of care. Do they have a clinical follow-up? Do they even have a doctor to go see? Are we just hoping that they'll make an appointment with whomever, and they're not even plugged in? Maybe they don't have insurance. Even though we're in an affluent area, we get a lot of patients who haven't signed up for ACA, who maybe aren't even in the country legally, or may not be. Bottom line is they need health care. So how do we deliver it to them? So we're really challenged. We have this big group. We also, the mortality for heart failure in 6 years is 80% men, 65% women. So there's a high cost in survival. And, but anyway, we have a lot of it, and the financial cost to our collective resources is staggering. So what do we do? Well, first of all, how about prevention? We talk about risk factors and smoking, and luckily in California we're sort of in the vanguard. When you go to other states, you really notice how much smoking there still is in public. And smoking is a really huge contributor to cardiovascular disease, but there are other contributors too. So the irony is we've kept people alive who would have been dead, had they been same disease state 30, 40 years ago. I mean, even cardiac care and PCI, that's changed a lot in the last 20 years. So we have more therapies. We have implantable cardioverter defibrillators that will basically resuscitate a person at home out of their lethal arrhythmia when they might have dropped dead in the past. We have statins that have allegedly reduced deaths due to coronary artery disease, and we have a growing elder population. My parents are examples. My dad will be 90 next year. My mom's in her 80s. They live in Palo Alto. There are a lot of seniors in Palo Alto. And at Stanford, we have some people see people who are well over 100. We had a lady that was 114. I think she did probably pass away. But people are living longer, so they're going to have chronic disease that they need help from us to manage. This is showing discharges for heart failure over a 30-year period of time from 1980 to 2010. And this square at the top, this top curve represents women. More women in the hospital than heart failure. And you could posit it's because, yeah, they live longer. And you could also posit that back in these days, they were undertreated for cardiac disease, because women are sort of patted on the head and dismissed when they presented, because they present atypically very often, etc. So we have this growing hospitalization, growing cohort that we need to pay attention to. This is a little bar chart that simply illustrates that in the younger age cohorts, like young adults, and God forbid young adults might have heart failure, but we know we have a congenital heart disease population. Luckily, it's relatively small, where basically in these younger adult cohorts, men outstrip women, but again, by 80, there's more women. This is prevalence. This is not hospitalizations by age and gender. Women outstrip men. So, as I mentioned, reducing readmissions for heart failure is on the national agenda, and it's not a joke. It's a very serious thing, and it's going to probably expand to every patient and every diagnosis. That we don't want patients coming back in 30 days, because it does imply we failed them on the acute care side. We failed to help ensure that they understood their medicines, they understand their diet, they know who to call when they leave our doors, when they have symptom recurrence, etc. Besides calling diastolic, systolic heart failure, the filling problem, the squeeze problem, we can have isolated left and right heart failure. But believe me, if a patient has right heart failure, they're going to have left heart failure over time. For the very reasons we talked about earlier, the right heart not only sends blood to the lungs for oxygenation and carbon dioxide exchange, but it also primes this pump. And if it starts to poop out, this side's going to follow suit. Who are the patients with exclusively right heart failure? Generally, they're patients with long-standing pulmonary disease. It could be COPD and emphysema. It could be interstitial lung disease, ILD, some other form of lung disease. It could be something called pulmonary hypertension. And Stanford, UC, our Centers for Pulmonary Hypertension, I think also Kaiser San Francisco. It's a very specialized disease. It can be idiopathic. It's a very serious disease. And the saddest thing is, the secondary forms of it are often young women in their 20s and 30s who are just starting their careers or their families, and maybe just had a baby, and they now have this pulmonary hypertension diagnosis. And it's a very serious and pretty much fatal disease, although patients can survive quite a long time, but it usually requires super expensive therapies like IV Flolan or subcutaneous Remodulin infusions at home oxygen. It's just awful. Or maybe a transplant. But anyway, high pressures on the right side will cause right-sided heart failure. And these patients, what's coming in the plumbing? What's connected to the plumbing for right side of the heart? Well, the portal system. So these patients will get hepatopathy, congestive hepatopathy. Their livers will swell up, liver enzymes will go up, terrible lower extremity edema, ascites, terrible body image issues, and as well as poor function. So that's right-sided heart failure. Left-sided heart failure is what we normally think about. We think about heart failure. The patient who's got forced squeeze, the patient who has fatigue, low energy, can't do things, is breathless, going up one flight of stairs, and things like this. So again, if they have isolated right heart failure, they eventually will have left-sided. Many of our patients have biventricular failure, especially the dilated cardiomyopathies. Heart failure arises from many causes. As well, I talked about congenital a little bit. So patients that were born with congenital anomalies, sometimes they can be fixed rather well, and some patients will require a series of surgeries depending on what they have, like tetralogy of the lobe. You can have a tachyarrhythmia-mediated cardiomyopathy, incessant tachyarrhythmias that actually change the shape of the heart over time if they're not recognized and dealt with. Valve disease. Most common toxin might be alcohol, but we do have alcoholism. Patients who present who 20 years ago were treated with for non-Hodgkin's lymphoma with a certain agent like adriamycin. 20 years later now have heart failure. And they were 20 years old at the time of the original treatment. Now they're 40, 45, and they've got heart failure, and we're talking about transplant with them. So there's lots and lots of causes, but the two most common are these that are bolded. Basically, coronary artery disease, or ischemic cardiomyopathy, and hypertension. What happens with both those entities is that there's actually first thickening of the heart muscle in an effort to do a better job of delivering blood, and then over time there's so much pressure left in the chambers of the heart because you're not got good forward flow, you're ejecting less blood with each beat, that the extra pressures within the heart chamber will cause dilation, and the heart becomes foggy, as if you blew up a latex balloon a number of times. About the 5th or 6th time it doesn't go back to its original shape. That's what happens with the heart because of this intense wall stress, because of poor forward flow. And I won't go into this cascade. My message here is that myocardial remodeling is a bad thing. It's a change in the conformation and shape, structure of the heart that causes it to function less well, and this is why we give beta blockers and we give ACE inhibitors to target certain receptor sites to interrupt this normally occurring compensatory cascade that actually hurts the heart and the body. So we can do what we call reverse remodeling, and this is typically what happens. The normal heart's like a nice little fish-shaped football in your chest. And when it's challenged, when it's challenged, it actually thickens up in an effort to be, it's just like working out your muscles, so you have more strength, that it can actually eject blood more efficiently through the aortic valve in systole. But those high pressures exert a toll and a lot of wall stress, and you end up with a basketball heart. A big, buggy basketball heart that fills the chest on x-ray like this. If you saw a chest x-ray like this, the diameter of the heart side to side should be no bigger than 50% the side to side diameter of the thorax, and you only have to eyeball that and see it's enormous. And here's another view. Obviously a transverse view. Here's your left ventricle, here's the right ventricle. Even the right ventricle is actually dilated. This is enormous, and you don't have squeeze. You just have this buggy thing and the patient's not feeling well, believe me, so you have an imbalance. I won't belabor this, but in the charting or documentation or the literature you might read, you may see reference to New York Heart Association classifications in the Roman numerals 1 through 4, with 4 being the sickest. This is an assessment of how bad the heart failure is from a functional status point of view. And so you're using symptoms as a guide, the patient's subjective symptoms. If they tell you that they're short of breath with moderate exertion, like I don't know, going upstairs with a bag of groceries, they're class 2. Middle exertion, maybe doing even less than that, walking the dog on a flat plane, gets them short of breath, that's class 3. And class 4 is, these are your cardiac cripples, if you permit me to say it that way. People who are in bed, and they usually label themselves that way and are afraid to do anything because they're so symptomatic. They just park themselves in a chair, and their day may be going from the chair to the bathroom, the chair to the kitchen, and that's it. And that's no quality of life. So Dr. Sharon Hunt, who actually is one of our cardiologists, led us a consensus group, American Heart and American Cardiology, and developed stages. And they don't supplant or replace New York Heart Association, but the stages are important. Why? Because we have to think proactively. Let's identify risk factors. Patients don't even have a diagnosis. They're not even sick yet, but they're diabetic, they're overweight, they don't do anything, sit in a chair and watch videos all day, etc. They have risk factors. Maybe they smoke. Stage B, they don't have a diagnosis either. These are 2 preclinical stages, but these patients are actually now developing structural changes to their heart. That won't be discovered unless there's a reason to do an echo or some kind of imaging or some kind of functional test. So they don't have a diagnosis. And then stage C, these are heart failure patients on medicines and eventually titrated up on the evidence-based medications to the evidence-based doses, and if they go to stage D, they're not responding to those medicines anymore. And we're either talking about mechanical cysts, like an implantable LVAD, either as bridge to transplant, or as destination therapy for those patients for whom transplant is not an option because cancer history, age, whatever. So So the idea then with Dr. Hunt and the group's introducing of stages is we want everybody, primary care physicians, internal medicine physicians, to be proactive and start treating these patients. We're putting them on these recommended drug therapies early so they don't go on to develop heart failure. And so again, we talked about tachycardia being the first body's compensatory mechanism that over time is harmful. People shouldn't be tacking away at 125 for no reason. There should be a reason if they're at rest. And atrial fib, again, where you have multiple foci. Actually, we know now, but it's mostly in the left atrium, where these foci fire and override sinoatrial node activity. So you've lost atrial kick, and for a heart failure patient, that's a big deal. For a lot of our elder population that walk around with chronic AFib, they do fine. They go golfing, they go shopping. Doesn't ruin their day. But if you've got heart failure and you've lost atrial kick, it's a double whammy. They really feel it. Why do heart failure patients die? Well, if they die of an arrhythmic death, it's much likely to be VTVS, over 50%. And then the next biggest will be Brady dysrhythmias. So there's a formula for calculating cardiac output, which very simply is the amount of blood pumped by the body in a minute, and we express this as liters per minute. Even though when we talk about stroke volume, we're talking about milliliters per minute. Most of us, let's just say, pump about 70 mils per liter. Do we empty out our hearts with every beat, or left ventricle? No, there's always residual blood. So the part that's ejected through the aortic valve is called ejection fraction, and you should know that. And you should know that none of us have 100% ejection fraction. Normal would be 60%, maybe 55%, and up is normal ejection. A very well-conditioned athlete, somebody who's around here in the hills on the weekends cycling one of those cool suits, or a runner, probably has a very high ejection fraction and a low resting heart rate because they have a great stroke volume. They don't need a high resting heart rate. So this is the formula, just something you should know eventually anyway, if you don't know it now. I don't think you need it for the boards. So what determines how much blood is pumped out each beat? How much is priming the pump? We call that preload. How much the heart resistance the heart is facing to eject? I call that afterload. That's blood pressure basically. And contractility, which is the intrinsic property of the heart to contract independent of other factors. So basically, a resting cardiac output at rest is somewhere between 5 and 7 liters, but we index it to body surface area. Cardiac output for a guy who's 6'4" and 250 is probably not good at 5, where it's fine for a woman that's 5'1" and 110 pounds. So we call it cardiac index. You don't need to know that. But I'm bringing these concepts up because these are the very things we manipulate therapeutically, preload, afterload contractility to treat the patient. We give DIG, which is the only oral inotrope that improves contractility, which they can take at home. We don't give it a lot as much as we used to because it's got a lot of problems. It's got a very narrow therapeutic range. We can reduce afterload by giving vasodilators, ACE inhibitors, beta blockers. Preload, we want to optimize the patient's status. We want euvolemia, whatever that actually means. We want enough basically to prime the pump, but not so much their neck veins are up to here and they're full of fluid and it's basically waterlogged. So there's an art to this as well as a science. That these are the things we manipulate either in an ICU setting with a lot of IV drugs or actually chronically for an ambulatory patient. So I just wanted to give you that sense. And contractility is just the inotropic state of the heart independent of changes in preload or afterload. And we have a lot of IV drugs we can give that improve contractility, like in the cardiac surgery setting, epinephrine, norepinephrine. We don't usually give those drugs to heart failure patients. If we need inotropic for a heart failure patient, we'll give dobutamine, which also has alpha effects and vasodilates and lowers the afterload. So there's a lot of things we do. And the good news is that we have things at our disposal. We want to improve tissue perfusion. That is the job of the heart. What we used to say is O's to the toes. Heart's job is to deliver oxygen to all the tissues of the body. And these are the different mechanisms for causing the symptoms. Actually, I have a better slide. But patients understand this. This is how they're feeling in a day doing ordinary activities that you and I take for granted. So it's all about quality of life. In the patient who has a bad right heart failure, they might have this kind of very extreme edema. You've seen pitting edema, right? 4+, we grade it by how deep it is, how many millimeters the indentation leaves. And their livers get engorged, their enzymes go up. The good news is their liver function improves once you diurese them and get that extra fluid off, if it's because of heart failure. And the clinical evaluation, the usual things, total ECG, basic labs. Eventually they'll be sent to functional studies. A very common one might be a treadmill, a treadmill or a bicycle. For some patients can't exercise, as you know. They just don't have the capacity. They're very elderly. They may have arthritis or something. So we do what we mimic our exercise by giving them dobutamine, provoking a higher heart rate response so they can see how their heart behaves on imaging when it's challenged because they cannot exercise. There's lots of options for us. This is an odd cardiac marker. It's called brain natriuretic peptide. And it was identified from study of rat brains, but it's actually a substance excreted by the human ventricle, believe it or not, when it's stretched. It's a normal peptide, which is a subfraction of a protein that the body sticks out into the bloodstream. And guess what? Natriuretic, what does that mean? It means it pulls sodium and it basically causes diuresis. So when the ventricle is stretched from volume overload, the body tries to compensate by coming up with its own diuretic agent. And we actually use that as a marker. And at Stanford, we use a sub-diagnostic. We use the NT-proBNP. But one thing I want to impress upon you, just like when you're going to deal with arrhythmia patients, you always treat the patient, not the arrhythmia. Some patients tolerate arrhythmia. Well, a single lab test isn't a diagnosis. You have to put the constellation together. If you have a very morbidly obese patient, they might actually have a low BNP because they just do. They don't have the same response as a person who's normal weight. So they'll have a low BNP, but they're actually in heart failure, and you can see it from other things, like you see pulmonary edema on X-ray, you see other things. So don't ever go by one little thing and say, oh, this person has to have that. Just like I told you, a person who's on dialysis, end-stage renal disease, very often will have elevated troponin. Usually not above the threshold to indicate MI, but healthy people should have 0 troponin, but they probably have micro damage to their, because of the disease. So we never hang our hats on one little parameter, but we put the clinical picture together. Echo's super if you have a chance during your rotations or when you're starting your practice to witness one. I think you'll be fascinated. Very easy test that can be done in clinic or at the bedside and can give you all this information. Sure, I'm here. Oh, I am. Cardiac exam. Just be aware that by listening or palpating, you can tell a lot about the heart. On a person with a super enlarged heart, the point of maximal impulse is where the apex hits the chest wall, because the apex is the most forward presenting part of the heart. The heart is tilted in 2 planes, right? The base of the heart actually faces the posterior chest. So if it's over here laterally and it's thready, this person's got an enlarged heart. You can tell that just by feeling. You can see a lot. A person with pulmonary hypertension, with a lot of right heart cardiomegaly, if they're slender enough, they're laying in bed, you will actually either see or feel, because what's under your sternum is actually right ventricle, not left ventricle. The heart's, like I said, tilted in 2 planes. So get that picture in your mind. You can elicit a lot just using your senses and powers of observation. And I think that's really interesting. And same thing for neck veins. And what you're looking for is not how far, you're looking for pulsations, and the highest point of pulsation, you can actually come up with a measurement using a formula if you want. Actually estimate central venous pressure, right atrial pressure. Here's a lovely picture of pulmonary edema. Here's the hilar lung where the lungs come off. This is all fluid, all this white. Air is black. We want to see black. We don't. We see all this fluid. We see blending of the costophrenic angle, and it's right up to the apices. So this person is not feeling or breathing tip-top, probably very tachypnic, probably leaning forward. You can also do an assessment of hemodynamic status when you hit the door and you're looking at your patient. Are they warm and dry? That's where we want them in this northwest quadrant. If they're cold and wet, you got a problem. This person's really sick and really poorly perfused, and probably needs a lot of attention right here and now. So I know this is super simple, and I'm running out of time, so I apologize. But these are some of the lists of common drugs patients are on. Not everybody's on all of them. I mentioned to you that ACE and beta blockers are sort of the hallmark first 2 agents to start, usually at low doses. And of course, that's ACE receptor blocker. angiotensin converting enzyme is the drug of choice, and then this is the secondary drug if they can't tolerate ACE. And many people who are African American who have high blood pressures are often on a hydrolysine and nitrate combination because they're usually refractory, or often, I should say usually, often refractory to other agents to bring their blood pressures down and lower their afterload. Not everybody goes home on IV diuretics, and many patients with only the filling problem, the diastolic or PEF, heart rate with preserved ejection fraction, will only need diuretic when they come into clinic or into the ED. Especially your frail elderly lady often will respond very robustly to 1 or 2 hits of IV diuretic and can be discharged from the ED and not be admitted. So this is our goals for therapy for acute heart failure, and there are drugs for that. I told you DIG is the only oral agent for improving contractility, and this, which you have in your handout, shows the cascade of decompensation and where the drugs fit, the different categories of drugs fit to improve heart function. And at Stanford, because we do mechanical assist, we have patients going home with the hardware. We actually have done a few patients with a total artificial heart. That's a very tricky procedure, as you might figure, and it's not like it's totally contained within the body. All these things have drive lines that exit the body. So these are how the symptoms originate, and I'm going to show you now. This is chronic heart failure. Same kind of goals as for acute heart failure exacerbation. We want to improve structure of the heart. Beyond anything, we want to improve survival, but quality of life matters to patients much more than years, honestly, and I think that's true for me, I can say. So symptoms matter. We teach patients symptom recognition and what action to take when they're getting worse. Some patients never will have no edema. They'll always have some lower extremity edema, but they need to know when it's getting worse and who to call. And that's your typical patient exacerbation, really distressed. And they may be cloudy on their thinking. Why? Because of your volume overload, you're diluting your serum sodium. What happens when you have a low serum sodium? You actually get brain encephalopathy. You actually have swelling of the brain, and patients get cognitively cloudy. Interesting. It does get better. So all those things to think about. And also on this patient, one other point I want to make is he looks very robust because he's kind of got a big torso. This man, actually, if you look closely with your very astute eyes, but you recognize he's cachectic. Doesn't that sound weird? You would see on this type of patient muscle wasting. They've lost muscle mass, and many times they're actually accumulating fluid, trading fluid for muscle, and muscle weighs a lot more than fluid, really. So they start to lose muscle, they got fluid, they think, oh, my weight is stable. I'm doing my daily weights like we tell them to do, because we want them to track fluid retention. And this is a tool we use to help them understand symptoms and when to go to the emergency room. And you'll see things like that. We didn't originate. We originated the stoplight thing, or at least our upside-down stoplight. But there's a rainbow tool that's out there by IHI. But this is our job as clinicians, is to teach our patients. This is a biventricular pacer that not only regulates the heart rhythm, keep it low, and help it function well, but actually paces the left side of the heart in synchrony. This is only for certain patients that have a very wide QRS. Wide QRS means it takes a very long time. The width of a complex on ECG is a function of how much time it took to depolarize. That if we can tighten that QRS by pacing them, they actually feel better, have better cardiac output, and over time have actually structural changes to the heart. They're favorable, and also defibrillate them out of bad arrhythmias. These are some of our tools, the tools that we use in short term to support the heart function. Tandem heart, we use all these at Stanford, many hospitals do as well. And these are some of our implantable devices that we use, including the total artificial heart. And then finally, transplant. And again, there aren't enough, our survival statistics at Stanford are very good, but the problem is we have twice as many people nationally waiting for hearts. That's why it's so important to develop this artificial heart technology, to keep people alive and when a donor heart becomes available. Another role for us is just to introduce us bedside nurses should be rethinking about palliative care, which is not hospice. It's treating symptoms and recognizing this person's kind of nearing the end of life and helping the families cope and helping the patient cope. So it's something that you'll see in your careers develop even further, because we haven't done a good job of packaging and describing what palliative care really is. Any questions? That was kind of the turbo version. If you look at this slide, this is what we really emphasize for education for our patients. And I really thank you for your time and attention.
Thank you.